Okay, so I'll go ahead and start things off. Thank you to everyone who's called in, and thank you for coming to tonight's Evenings with Genetics seminar about achondroplasia. So this is a seminar series that's sponsored by the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital. And for those of you who don't know me, my name is Amanda Gerard. I'm the genetic counselor for the Skeletal Dysplasia Clinic at Texas Children's. So I'm going to be helping to moderate tonight's session. I'll be introducing our speakers, and then I will be helping out with the Q&A portion of the session that will be happening at the end of the seminar. So as far as how things are going to work tonight, Dr. Pacino is going to be our first speaker as our physician speaker, and then we have a family speaker who will be talking as well. And then at the end of the session, we will have the option for a Q&A for a few minutes at the end of the session. And my cat is meowing outside of my door, so I'm sorry if anybody can hear that.
Yo soy Amanda Gerard, soy consejera.
So there will be an option to enter questions. You should have a Q&A button in your chat, and you can enter questions at any point during the speaker presentation, and I'll be kind of moderating those, and we'll help to ask some of those of the speakers at the end of the seminar. You also have the option at the end to unmute your microphone, and you can ask questions that way during the Q&A portion of the evening as well. There will also be in the chat towards the end of the seminar a evaluation link, and if you are able to click into that and just take that brief evaluation, that's really appreciated for us in helping to plan future seminars as well. So I'll go ahead and introduce our two speakers, and then we'll let Dr. Bacino start things off. So Dr. Bacino is our first physician speaker. He is going to be talking today about achondroplasia, as well as the Skeletal Dysplasia Clinic, where we see a lot of those patients at Texas Children's Hospital. He's primarily devoted to clinical activities in the Department of Molecular and Human Genetics at Baylor College of Medicine and Texas Children's Hospital, and he's actively involved in the diagnosis and management of pediatric patients with birth defects and rare genetic conditions. He's also involved in the supervision and training of medical students, residents, and fellows, and he's the chief of the genetics service at Texas Children's Hospital, as well as the director of the Pediatrics Genetics Clinic. He's closely involved in the study of bone disorders, and as I mentioned, he's a provider in the Skeletal Dysplasia Clinic at Texas Children's Hospital, and through that clinic, he's cared for hundreds of patients with a variety of skeletal dysplasias, including achondroplasia. As part of his work related to skeletal dysplasias, he's also involved in several research studies related to achondroplasia, and these are available through the sponsorship of a private pharmaceutical company. And the goals of these studies include looking at body measurements and proportions in a cohort of patients with achondroplasia and enrolling patients in achondroplasia for a phase 3 clinical research trial, which uses recombinant cartilage natriuretic peptide, and we will talk about what all of those words mean, also known as vosoritide, and this is a medication that's anticipated to promote linear and more proportional skeletal growth in patients who have achondroplasia. Dr. Bacino tonight will be speaking further about these research studies and discussing general information about achondroplasia and associated management based on his years of caring for patients with achondroplasia in the Skeletal Dysplasia Clinic. After Dr. Bacino speaks, our patient family speaker will be speaking as well. Our patient family speaker this evening is Mr. Adarsh Berkeria. Mr. Berkeria is the father of a teenage son with achondroplasia, and he's involved with the Little People of America organization and previously was the president of that organization's Houston chapter for several years. So Mr. Berkeria will speak this evening after Dr. Bacino about his family story and about the Little People of America organization. And I will, for now, turn things over to Dr. Bacino.
Thank you, Amanda. Thank you very much for the introduction. And by the way, Amanda Gerard is a genetic counselor that has been helping us for quite some time now in the Skeletal Dysplasia Clinic. So she's actually one of the contact persons and quite knowledgeable about a lot of these conditions. So let me share my screen. And what I would like to do tonight is try to give you a little bit of a summary of what is the condition like achondroplasia and what is going on in terms of what are the needs, what are the problems, And what do we do now to treat these kids, and certainly what's coming, to give you a little bit of an idea of what treatments are coming in the horizon. So I don't want to get too technical, and some of my slides may have technical information, but I will try to make it simple, because even though there are some providers that may have medical knowledge, many of you do not have that luxury. So essentially, achondroplasia is one of these groups of conditions called skeletal dysplasia, so bone disorders that are associated with short stature and other medical issues. Certainly is one of the most common of the group. And so far, there are about 450 something in terms of number of conditions that affect the bones and the growth of the bones. So this is a pretty crowded group, but achondroplasia happens to be one of the most common conditions that we see in the clinic. As you see, the incidence is not that rare, at least not for us. We do work with a lot of children with relatively infrequent conditions. So our clinic has a pretty large representations of children and individuals with achondroplasia. This is a dominant condition, which means an autosomal dominant condition. For genetic means that a single gene change that affects a particular instruction called the fibroblast growth factor receptor free is what causes achondroplasia. Most of the time, about 80% of the time, these changes happen to be new changes or new mutations. And so often families wonder why this happened to them. And it's just one of those things that happens often that has nothing to do with the parents or their genetic background. So there is a change in this particular instruction called short for the fibroblast growth factor receptor free, called SGFFRfree, at a very specific position in this genetic instruction. And it's interesting because this particular change in the SGFFRfree tends to repeat over and over and over. It's most of the time it's the same in all children that have achondroplasia. This is a picture that I took from Orphanet, an Orphanet article that is available to the public. And this shows a number of different children with achondroplasia, very cute kids. They do have some different changes in the way that the head is shaped. So they tend to have a little bit of a fuller forehead. And because of that, the nose seems to be a bit more flattened. And the head tends to be larger in general, which is something that we call macrocephaly or short, sort of for large head, and also mid-face hypoplasia, which is basically the flattening of the middle part of the face. That certainly doesn't cause any significant problems, although this mid-face hypoplasia could be associated with problems with the breathing and issues that have to deal with the passage of the air. These kids have overall short stature and certainly changes from patient to patient, but there is something that that is commonly seen in these kids, which is the extremities are also shortened, and sometimes the proximal part of the extremities is slightly smaller, and that's something that we call rhizomelic shortening, which is sort of the proximal part of the arm and the proximal part of the legs, the part of the legs that is attached to the hip. And there are some other clinical findings like these Triton Hands, which is just the shape of the way the hand appears. And that is just because of some shortening of the bones of the hand. This picture shows an X-ray of the hand of a child with achondroplasia, and here essentially what you see is that the bones in the hand, that they're all shortened, and sometimes you can see sort of this deviation of the digits called trident shaped hand. And on the right is the hand of a kiddo with achondroplasia that shows a smaller hand. Essentially, they're functionally the same. They're completely normal, except for the fact that they're shorter. So we can see a child in the clinic and suspect achondroplasia, and this is something that is relatively straightforward, given some of the clinical manifestations. Sometimes it may be a little bit harder, and then we go and do x-rays. So these are just an example of x-rays that are done on a kid with achondroplasia. On the left, you have the x-ray of the hip and the legs, and the proximal legs. And the hips are quite characteristic. They have a sort of a rounder shape. And because of these, and because of the way the long bones, in this case the femurs, look like, we can pretty much make a diagnosis of achondroplasia just based on the bone appearance. In this particular case, you also see that the femurs, which is the bone that is attached to the hip, is slightly shortened. And on the right, I have a picture that I put, which is a picture of the spine of a child with achondroplasia. And why did I do that? Well, one of the things that we are concerned in medicine is not just about the height or the arms. We also care about other bones and other parts of the body. What you see here is that the spine, as usually normally as you go down the vertebra, the number that you can see, these are in millimeters, so you can see 10.66, and then you see 10.3, 9.7. This is something that we see in this particular condition, and that is because there is a narrowing of the spine. And that's something that is fairly normal, and you can see in all individuals with achondroplasia. And that's one of our concerns, because we know that from the start, some of these kids have lesser space in the spine. So these are the bones that are going to house, you know, the part of the nervous system, which is the nerve part of the spine. So because of, you know, our practice, you know, we are familiar with some of the problems that happen in these children, and these are sort of like the most common issues that you can see in children with achondroplasia. One is they tend to have a lot of ear infections, just because of the way that the bones in the ear are formed. They tend to be a little bit deeper, and they tend to be narrower, and that causes more issues when there are you know, infections or congestion. So these kids tend to have more of these infections, and that may require very aggressive treatment because that can lead to hearing loss. Early on in infancy, we worried about cervical medullary compression. So what is that? That is compression of the spine just underneath the skull. These may happen anywhere between 10 months of age to 18 months of age. So we monitor that very closely. Some people will do imaging in all of these kids. We tend to be more conservative and then follow clinically and decide whether that is needed or not. Leg bowing is common. In the early part of the childhood is because the knees are very soft, they're very lax. And so that's not usually a problem. But that may cause issues, with your child starting to stand up or even walk just because of that flexibility of the knees. And later on in childhood, some of the kids may actually have bowing because of one of the bones called the tibia may bend, given some also unusual growth of the fibula, which is the other bone in the leg. And that can be easily fixed by surgery. And that's something that the orthopedic doctors can do pretty easily. I already told you about the lumbar spine, when there is this narrowing in the spine, and it usually becomes more of an issue as the children are past the second or third decade. And that can result in issues like leg pain, and it could certainly be more severe in some cases. And one thing that, because of the short stature, and that happens with a lot of kids that have short stature, obesity is a potential problem. And that actually obesity, that ultimately may lead to other medical problems like hypertension and diabetes. So again, I don't want to become very technical, but this is a cartoon of this genetic instruction called the SGFFRfree. And the SGFFRfree has different portions, and the one portion that is associated with achondroplasia is the one that is in the middle, and that's the one that is inside the cell membrane, and that is typically the same instruction that is effective all the time, and it's quite classical to find the same mutation for pretty much 95% of the kids that have achondroplasia. Interestingly, there are a lot of other conditions that are associated with problems in this same gene, depending on the part of this gene is located, whether it's in the portion outside the cell or the portion inside the cell. And some of these can be very significant medical problems. Some could be conditions that are milder forms of what I will call achondroplasia, that is called hypochondroplasia, which is a similar condition that has a lot of very similar features with achondroplasia. So why FGFR3 changes cause achondroplasia? Well, we know that the bones have the very end something that requires a number of growth factors and hormonal changes and signaling to grow, but in the same way that the bone grows, the bone has to grow, stop, and this signaling is something that is very involved with the FGFR3. Why is that? So while the bone is growing, the SGFFRfree is the signal that comes to make that growth stop or slow down. Now we know that these change in SGFFRfree makes this fibroblast growth factor receptor more active. So, and because of that activity, it sort of is sending the signal to stop growing to the bones. So normally they should be acting on and off, but in achondroplasia, what happens is that this gene is actually sending this sort of inhibitory signal, or stop growth type of signal. So now we know that this mutation causes this, what is called a gain of function mutation, meaning that this gene is now working in overdrive, and that is what is putting a damp or putting sort of a brake on these signaling and causing the bones to grow much less than in other children. So this is something that I often show to the medical students, and this is just to exemplify what happens in the fibroblast growth factor receptor free. So this is a situation where these fibroblast growth factor receptor sort of is sitting in two different pieces, and when you get something that is called the binding factors or the FGF, they actually activate these two parts and they come together, and then they send this signaling that goes inside the cell. And what is going to happen that ultimately is going to send all of the information for the growth to stop. And this is kind of important because some of the treatments that are coming now in the clinical research area, they either work modifying this particular factor, which is basically this what is called the STAT kinase and MAP kinase phosphorylation. And there are some other studies that actually are starting to work with this particular part, which is these fibroblast growth factors, and I will show you this in a minute. So you need the signal, the FGF, to bind to this receptor and then do this whole cascade. So that brings me to the treatment. So I can tell you a little bit about what we have been doing for now decades, which is essentially trying to do or fix all of the things that are causing medical problems. In other words, if you have a compression of the cervical medullary spine, there are some surgeries that you can do to release part of these the spine right below the skull, and that will actually decrease the pressure that is building up in these children's spine and brain. You can do a release of the spine in older individuals that have achondroplasia, as they may have significant stenosis. You may do the surgery on the legs if there is some bowing. And more lately, I would say in the past, 20 years, it has become very popular, the use of limb lengthening procedures. And this is something that it was done with some pretty, I would say, hard type of treatment. They will break the legs, they will put some external fixators and something that is called the Elizarov procedure that basically require a child to be in a wheelchair for a year's time until they can go through the whole process. and lengthening the limb. Now there is another procedure that is done with a rod that is put inside the femurs and the humeri to essentially to make this rod sort of stretch until the limb grows longer. Needless to say, this is something that only very few people do or can afford, because we are talking about surgeries that cost hundreds of thousands of dollars. Obviously, this is not practical and is associated with a lot of morbidity. Now there are a number of therapies, and actually many of them are already coming into the clinical research arena. One of them is already working with some, there is a pharmaceutical company that is now producing a drug called bosoritide, which is this C natriuretic peptide, or short for CNP. And this is something that now a second company is coming also online, that is just started with this treatment. I will show you what the difference are between these two. There is another therapy that is called the decoy therapy, which is a soluble SGFFRfree receptor. And this is something that was originally put together by a Swiss company, and that company was bought by Pfizer. So Pfizer is now starting this trial, and there are a number of companies that are looking at these tyrosine kinase inhibitors. So the one that there is the most data about is this trial that was done with bosoritide. So bosoritide is this drug called this CNP analog that we know that works at the end of the bones in the areas where we know that the defect happens in achondroplasia. So kids with achondroplasia have been receiving daily doses, subcutaneous injections of this drug for a number of months and years. And there have been a number of studies. There was the initial phase 2 study that have those patients. You can see is the graph on the right side. You can see the different colors, and I would like you to focus on the blue and yellow colors. That represents the patients that receive 15 micrograms and 30 micrograms of this drug per kilogram. And what is showing you that these are the measurements of these patients at the time they started the trial. And on the right, you have the patients that were looked at 42 months when they went through the trial. And what you can see is that for the blue and the yellow bars, you can see that there is actually significant growth over time for all of these kids compared to the baseline. So one of the things that I wanted to show you is that the dotted dark line that you see on the bottom is the expected annualized growth velocity that is expected for children with achondroplasia that have not received any treatment. And on the top, you have the solid line that represents the annualized growth velocity that is expected for children that have regular height. So in other words, what's going on that over time, you see that the kids receiving this drug called bosoritide, they have been gaining in terms of height to a level that it was almost close to what was expected for children of average stature. So this was followed by a phase 3 trial. So what is a phase 3 trial? That's when you have your drug, and now you have to prove that this drug does work compared to children who are not receiving the drug. So what you do in this circumstance, you put some children in placebo, meaning that you're injecting something that doesn't have any drug, and then you're injecting other children that have the real drug. So this is what happened at the time these patients were started. And when you look at the placebo at week 52, at a year, there has not been any significant change. But when you look at the children who at 1 year had been on the vosoritide, it shows that they have been growing, approximately 1.6 centimeters more. And this is something that has been has continued to show in the second year, and then there's more data coming up showing that this is something that continues to work. So more information is coming out pretty much on a yearly basis as these data is updated. So there is another therapy that is quite interesting, and this is what is called the soluble or SGFFRfree decoy therapy. Remember that I showed you that these receptor, these pieces had to come together to start acting on the bone to stop the bone. But what happens is, if you basically sequester all of this FGF, which is this particular protein that is going to attach to the receptor and start working on the cascade. So the idea behind this is that you basically give a drug, and this is what is called the decoy. So it's essentially similar to the FGFR-free, but it's soluble, and you trap all of these yellow pieces, which are the FGF. And the studies that were done in animal models and mouse model shows that actually this is a very successful approach. So with the CMP, you work in an indirect fashion, and something that it acts over these signaling that I showed you before, the MAP kinase. But in this particular situation, you just work directly in what is going to attach into the receptor. So this is the drug that is being now commercialized in clinical trials by Pfizer, and this is about to start for clinical trials in Europe and the US. And this is another company that is using this CMP or cartilage natriuretic peptide, which is long-acting. Remember, I told you that in the previous trial with the CMP, the injections were given daily. This company that now came out has this drug that is a long-acting drug, and what it does is the same as the vosoritide, but this laboratory claims that they have much more, they're more effective because of the constant release of this molecule in the blood, and that only requires weekly injections. So right now the phase 2 trials are underway. The phase 1 were completed actually, and it looks also pretty promising. So we went from pretty much conservative treatments and not much going on to a very crowded scenario where all of these companies are knocking themselves out just to come up with these very fascinating therapies. And this actually, it shows these were studies that showed that these particular drugs, the same as posoritide, causes significant growth in the different bones of juvenile macaques. So this is something that we now know it works. This is a picture I got from, because I have been involved in the trial with Rosarito, and this is one of my patients. The family allowed me to use this for another talk, and I didn't ask them about this one, so I decided to block the eye, so my apologies. But essentially, I wanted to show you this little girl. She was 5 at the time she was started, and this is at 5 years, and this is at almost 10 years. And this is, it shows, you know, her legs, actually, she never had any surgery, and nothing was ever done. And she now has a much better reach, and she has, she's able to brush her hair and do her hair. And one of the things that I don't think that any of these clinical trials are looking particularly is the craniofacial structure or the face structure. I think that this kiddo has actually changed quite significantly, and I think that some of the features of achondroplasia are not as marked as you will see in some kids. So certainly this is just an example to show you a successful story of a patient that I follow. Couple of more slides, so I would like to discuss more with you and take care of your questions, is what are the recommendations from us or your pediatrician with regards to achondroplasia? Number one, expect delays in all of the milestones. I told you a little bit about the joints are a little bit loose. Also, you're dealing with a larger head that sometimes is harder to pick up. So there could be delays in sitting, delays in standing up, delays in walking. But those are just transient. These kids are intellectually and physically normal, so they will do everything other children will do. You need to be very aggressive about treating ear infections because of the consequence could be significant, and that cause hearing loss and cause speech delays. If your child is having issues with snoring, sleep studies are indicated because this is something that can be addressed with ENT surgery, tonsillectomy and adenoidectomy, or also, you know, CPAP is something that can be considered. In those who have concerns of a head that is growing very fast, or their problems that, you know, neurological issues or weakness or things that suspect something going on with the spine, and this has to be referred to a neurosurgeon. One of the things that I recommend is the avoidance of contact sports, swings, trampolines. These are things that we take for granted, but it could be dangerous for children with achondroplasia. So this is something that you can learn also talking to other families, or even learning from the organizations like LPA. In young children, I also recommend for parents to use rear-facing car seats. And there are some attachments that you can put for having a strap to the seat to secure the head. Why? Because the head of this kid is relatively bigger, And as you know, the car moves and you flex the neck or the neck goes down, there is a risk for the spine to be compressed. So this is something that is very important for the young children or early infancy. Orthopedic referral for leg bowing. Sometimes occupational therapy can be useful for cell skills. And obviously, things that we don't think about, that families do is what do you do to your home? You need to actually do different low profile bedding, different furniture, just change your light switches and do all kinds of things to help these kids to be more independent. Weight management is an issue, usually not a problem until teenage years. And definitely, I hope that we're going to hear more, but parental networking is extremely important. And I always recommend the families to go to the LPA and get information about, networking with other families with achondroplasia. And I think that this is it for me. So I will stop sharing, and I think that we can continue with, I believe it's Mr. Berkeria.
I'm here. Can you hear me?
Yes.
Great. I've just turned my video on. Let me start sharing, and hopefully you guys can see this. Let me know.
Yes.
Great. So thank you, Dr. Pacino. That was a great presentation, and some of what Dr. Pacino covered, I will, I guess, kind of be talking about. Can
you open your PowerPoint presentation, because we only seen. Just put it in the presentation mode. Yes.
Is that better?
It still shows.
Okay, let me change. I think I need to just change the screen. Give me 1 second. I apologize.
I mean, you can see, but it's smaller.
Is that better?
Yes, that looks better on my.
Okay, great. Yeah, so I'm going to talk about my son who has achondroplasia, as Dr. Bacino had mentioned before, and then go into just a little bit about him and kind of how we deal with achondroplasia. So my son is Anand Berkeria. That's a picture of him from, I believe, 2019 when he started school. So he was born January 3rd, 2008. His diagnosis was achondroplasia. Now, in 2008, when he was born in Chicago, and we had a doctor after he was delivered that says, he looks different, and I mean, I just had a son, and so I'm not thinking about he looks different and what does that mean. And so I said, well, what do you mean? He said, oh, his arms are a little shorter and his legs are shorter. I'm like, well, he was just born. How can you tell that? And didn't think too much of it. And I was like, okay, we'll take some medicine. We'll figure it out. And not till we left the hospital did they really explain to us what achondroplasia was. And there was no test done ahead of time. My wife had no test done. There was nothing that told us that, he's going to have achondroplasia when he's born. And so we went and did some genetic testing. We went with a geneticist in Chicago, and, they ran tests and they did some stuff. And, they told us we had achondroplasia. And at first I couldn't even pronounce the word. I didn't know what it meant. So it was pretty emotional because, you have all these dreams and all these things, and suddenly you're thinking, well, all that's gone. But, I guess I'm here to kind of tell you that, yeah, some of it might be gone, but there's a lot of other stuff that comes out of this that, is very, very positive. So we've been a patient of Dr. Bacino since 2009. So Dr. Bacino has seen Anand every single year. And I think he'll tell you that he's, some of the stuff that he's able to do with achondroplasia is just so amazing. I mean, he plays soccer, he plays basketball, he's active in sports and whatnot. Cut out some of the things that Dr. Bacino mentioned. So when he was very young, he did have a flat head. As you've heard, their head is bigger and weighs a little bit more. So we did have to wear a helmet for a period of time, about 6 months. in order to mold the back of his head and the side of his head to get more of a rounded figure, so that he wouldn't have, it was purely cosmetic. But again, as they grow older, they wanted to do it super early so that you have a rounded head in the back and on the sides versus kind of more of a flat head. Ear tubes, we had ear tubes done twice on both the ears. And as Dr. Pacino has mentioned, we had the adenoids and tonsils removed. So we had 2 or 3 different sleep studies, and his adenoids were so big that he actually, the sleep study showed that he actually stopped breathing for a micromillisecond or something to that effect. And so the reason all of that came about was he was about 3 years old and he wouldn't sleep through the night. And so we went to the pediatrician to kind of say, hey, there seems to be a problem here. He's not sleeping and he still wakes up 1, maybe 2 times a night. And so the pediatricians were like, well, you need to go see an ENT. And that's when we discovered that the adenoids were, and the tonsils were severely enlarged and actually caused him to stop breathing in the middle of the night. And that's when he would wake up. Once we had the adenoids and tonsils removed, I mean, it was, me and my wife would actually wake up every single night to check on him because he wasn't waking up. And so we didn't know what was happening. And so it cured it immediately. The first day he slept the whole night, and, you know, we were super excited. As far as the lifestyle, he plays all the sports that he can. I mean, he's played soccer since he was 4 years old, and he's 13 now. And he's played basketball ever since he's probably about 5 years old. Now, it's not super contact, and we don't play in the competitive leagues. We play at the YMCA, but it's still, you know, competitive. And, you know, he enjoys it superly. And I think every year I ask Dr. Bacino saying, when do I stop? You know, is there a risk of him getting hurt? And I think Dr. Pacino will say the answer is he'll tell you when he's ready to stop, or when he's kind of getting beat up, or, you know, kind of pushed down too much. And so I think we're getting close to that age now. He's 13. And so now we're in the kind of 7th, 8th, 9th grade kind of age group. And so he's definitely, you know, kind of feel it a little bit more, but he still wants to continue to play. And I think we're going to let him, unless, you know, he gets some sort of injury. I think, you know, that's probably each parent will have to make that decision as to how they want to progress around sports. But he loves sports. I mean, he plays sports every single day, you know, with the friends at school. He was involved in Boy Scouts, or excuse me, Cub Scouts. So I think that the point here that I'm trying to make is they're able to do everything that normal kids can do. They were a little shorter. He might not be as fast as everybody else, and he's not going to win a track meet, but you know, he can still play all the sports. He can still do coding. They can pretty much do, you know, all the normal activities that kids can do growing up. One thing people might ask around is a 504 plan. So this is, you know, the plan that we have with the school for accommodations that he might need in school. So some of the things that you might consider or that might come up will be when they sit at a desk, their feet are not going to touch the ground. So they will need some sort of stool to have their feet so they're not dangling. Their back actually might not, you know, sit properly on the back of the chair. So they might need some sort of chair adjustment. In elementary school, he didn't need any kind of adjustment. He actually adapted to everything. He was able to go to the bathroom and use all the facilities properly. He was able to drink from the water fountain with stools. He was able to, you know, at lunch, get all of the food and, you know, do everything he needed to do. In middle school, the desks were a little bit bigger. So we do have stools in all of his classrooms. And the 504 counselor has also given us a pass where he can leave class 5 minutes early. As you guys probably know, you know, all the middle schools and high schools have thousands of kids. So we just don't want him getting run over between classes. And so he's allowed to leave 5 minutes early, you know, to kind of get to class without all the traffic, if you will. Little People of America. So I think on Dr. Bacino's last slide, he mentioned it. So I was president of the local chapter here in Houston from 2015 to 2019. And I didn't know what Little People of America was until Anand was born. When we first moved to Houston, I just sent an email to the president at that time. Her name was Pamela Roxbury. And she called me and she talked my ear off for about 2.5 hours, telling me everything about Little People of America, all about the support, all about the families that are involved, and how I needed to join. It would be the most, kind of beneficial thing for me. And 13 years later, I absolutely agree. The support that you get, because everybody who joins this club either has kids that have achondroplasia, or there's even adults that have achondroplasia. And it's basically a support group. It's a free questions group. Everybody there is to tell you, well, this is how I did it. This is what I did. This is the problems that I occurred, or these are the problems that I encountered, and here's how I solved them. For those of you, I assume most people here are from Houston. We do have a local Houston chapter where we have chapter meetings, 3 or 4 times a year. We have a regional event, which is Texas and Louisiana. So we meet in one of those 2 states. Usually before COVID, we met twice a year, in the spring and in the fall. We usually get about anywhere from 75 to 150 people. So fairly big number of people. It'll be in one of the bigger cities. So we have activities, we have meetings, we talk about things, we have some guest speakers that come in. And then every year there's a national conference somewhere in the United States, which usually has about 3,000 people from all over the United States. So if you haven't been to a national conference, you really should experience it. You meet a lot of new people. You get to see kids from all different types of achondroplasia and different circumstances, if you will, some good, some not, maybe not so good, but you really get to see that and talk to people and experience it. So there is a Facebook group here in Houston for the LPA, if you guys would like to join, or you could probably ask Amanda. I'm happy to send my personal email and have that shared if anybody wanted to contact me. That is all I have. I'm happy to answer any questions if anybody has any. I guess, Dr. Bacino, back to you.
Thank you very much for your presentation. I think that, again, it's very important to connect with other families and organizations, because the truth is that as much as we try to do, and genetic counselors like Amanda will help us, talk to the families after we done our visit, but there's so many questions that are still unanswered, and there's so many practical issues that oftentimes we don't even think about, that only a family that is dealing with a child with the same condition or group of conditions can actually come up with help. And what I find also very useful, that the LPA has lots of information about vendors and things that you can buy. Well, now you have Amazon, you can find everything on Amazon, but the reality is that before that, you didn't know where to go and get certain, items, from clothing to furniture, things that will be important for your daily life, issues. So, that's why LPA and other organizations are so important.
Well, thank you very much to both of our speakers. I just dropped a link in the chat for the post-seminar evaluation. So that'll probably be sent out via email tomorrow as well. But if people could complete that, that would be very helpful for us. And then we can go ahead and transition into the Q&A part of the evening. So I have a couple questions myself, and I've had a couple that have come through with the chat box. But if anybody has questions for either of the speakers, feel free to send those through the Q&A button, or I'll give people a chance to ask questions out loud and unmute their mics as well. But like I said, we did have one question that's come through the Q&A for Dr. Bacino, I believe. It was asked by one of our physicians who's called in, and I'm not completely clear if I'm asking the question correctly, so feel free to correct me, but I think it's about clinical trial opportunities for infants with achondroplasia. Are there any clinical trials that are open to infants currently, or that are expected?
So there are 3 companies now actively, the ones that I know, so there are probably more. So we have BioMarin, who's worked with Rosarito. All of the trials are closed because they have a trial for 5 years and older, and then the last trial was for younger kids. And they had 3 different groups, and the last group was already filled. So I bet that the BioMarin is probably close to get FDA approval in the next few months or even a year. So they're not having any more kids enroll. The 2 companies who are enrolling are the one that is the long-acting CMP or Ascendis. And actually, we have a site here in Houston, and then the one by Pfizer that is doing the soluble SGFFRfree or decoy therapy. All those are started. However, you know, there are not that many slots, at least that we have been given, and there are sites all over the world. So I think that they're probably saving now for the phase 2. They want to allot some patients to different sites. And so phase 2 may be a little bit hard. For phase 3, that may be a different story. One of these companies now is doing a mixed phase 2 free. So they're looking at those, and they're also doing drug and placebo. So there are opportunities for enrollment, and also there are other companies. Those are not that familiar with, because I don't have much time or opportunity to do so many trials, but it's using these tyrosine kinase inhibitors, which are essentially pills. These are medications that have been used for many years in patients with cancer. So they seem to work on animal models. Again, this is not something that I'm particularly doing. For the physician that asked before, you can send me an email directly. I can give you more information. The company, one of the companies, I believe, is called QED. That's the one that is doing one of the tyrosine kinase inhibitors.
Thank you. We've had another question come through from another of our physicians for Mr. Berkeria. And they asked about whether Anand has been involved with any of the clinical trials. And if you would be willing to either share your decision-making process, or if you know of other families who have gone through that decision-making process about why not people would be involved with the clinical trials.
So Anand, he has not been included in any of the clinical trials. Dr. Pacino did present some of those to us, but when they were presented, I mean, it was I guess a decision my wife and I made. We just didn't feel comfortable at the time. So he's 13 now. I think it was presented more when he was 5, 6, 7 years old. And at the time, we just didn't feel comfortable. We didn't know enough and really understand enough. And so that was the rationale for not participating.
And that was also a question I wanted to ask you a little bit about, Dr. Bacino, because I get this from a lot of families. Are there any common side effects, other concerns with any of the therapies that are out right now?
Yeah, it's a good question. I didn't, obviously, just for the sake of time, I didn't show much of that. These drugs, what they do is they have some control in what is called homeostasis, meaning that circulation and blood pressure. So potentially these drugs can cause a decrease in the blood pressure. And this is something that we have seen in some of the kids that we did this therapy. And the good news is that when it happens, doesn't happen in all of these kids, is transient, and it can be minimized by doing proper hydration, making sure when they take the drug in the morning that they had, their breakfast and juice and water. So it's not usually a significant problem. And the other one is the site reaction. A lot of these drugs can have a site reaction where you given the injection, and that's redness, and that typically lasts about 45 minutes to 1 hour and then disappears. So those are essentially the side effects that we have seen in these kiddos.
Thank you. We've had another question that I believe is for Dr. Bacino as well come through. Somebody wanted to know if you could talk in a little bit more detail about the mechanism of vosoritide and how that works for therapy.
So yeah, I mean, it may be a little bit technical, but it doesn't work with this fibroblast growth factor receptor. It works with a different part of another part signaling of the cell that is called the natriuretic peptide receptor. So what happens is that when you activate this receptor in the cell, the signaling that goes through that receptor actually stops the inhibition of the MAP kinase. So in a way, it's sort of you're stopping what is stopping. So then sort of interfering with this signaling that stops the growth. And that's how it modulates, the growth by causing this kind of loop. And this is actually information that was known for many years. There have been some people that by chance discovered that if they put some bones from culture bones of animals in CMP, they actually will grow. So tibia from sort of like small tibia from mouse, and this was something that was just found by chance, and then people started looking into that, and they realized that there was this sort of mechanism by which the CMP promotes growth. But it's a kind of an indirect loop. The other drug, that the decoy therapy, is going to be sort of a different story, just working in the SGFFRfree. The reality that seems to work, and again, one of the when families are presented with this particular information, obviously research is not for everybody. Research is for someone who wants, an answer maybe quick enough. But research cannot promise anything. So, when I presented this information to Mr. Berkeria many years ago, well, we didn't know whether this was going to work or not. So, families do not want to go through some of these very long years of research if they don't really know what's going to happen. So, I think that it's not for everybody. Certainly, we're very grateful for those families who participate that can make this happen. Once we know more about these medications, then we can present to the general population and say, well, this work, and this is what you can expect, and that's a different conversation.
Those are all the questions that have come through the chat. I have a couple that I can ask, but before I ask those, are there any additional questions anybody has? Anybody who wants to unmute themselves and ask any questions? Okay. Well, then I have one question for each speaker. I'll ask Dr. Bacino's question. So another thing that families ask me about sometimes with the therapies is whether they can help with some of the other complications that can come with achondroplasia. So obviously the height is significantly increased. As that happens, do some of the other things improve as well? Like you talked about ear infections, bowing, sleep apnea, those sorts of things. Mm-hmm. Does that improve as well?
That's a great question. So the issue is that we really don't know that, at least not yet. So there are a couple of things also to comment on. many of the complications that we see are complications, things that happen very early on. The children that have been going through the trial, the one that we have the data, are 5 years and older. So, and that population is not going to show you the compression of the cervical spine. Most of the time, the obstructive sleep apnea is resolved. So, you know, you will see different types of issues. We didn't see any changes in ear infections or other complications. What I would say also, the caveat is that this trial was not looking, for example, one of the things that worries me as a physician is the spine in these kids. And do we know if this drug is causing any changes in the spine? Well, that wasn't looked at. And you will say, well, why this hasn't been looked at? To do an imaging study on a child requires sedation. And getting that approved through research protocols is often very complicated. So this is something that now is being looked at the younger population, and it was posed to the researchers. It's like, well, we are now doing a drug trial in a younger population. We need to make sure that we are not doing any harm. So imaging is very important, and all of these kids are getting the imaging. So I think that may answer some of the questions. So is the spine getting bigger? Is the part that between the skull and the spine is as narrow as, you know, before? What is the change? Obviously, a lot of data will be needed to answer that. And also, you know, to see some of the changes with the ear infections and obstructive sleep apnea. So I think that this is something, my personal impression is that these drugs are going to make a difference. I think that it will take years until you can pull all of these kids and do an analysis and look at the data of hundreds of children. So one of the things that I also should mention is that no increase of this proportion was seen. So some of these kids tend to have a little bit of shorter limbs, although they get better with age, but nothing has, the drug have not caused any harm to these kids. So there has not been any problems with this proportion beyond of their condition. So we were hoping that perhaps, you know, we can improve and they can, the arms will lengthen. I would say that, you know, the case that I showed you of this little girl that I follow, I think that she has done quite remarkably well. Probably it's not what happens with all of the kids. I think that some kids may respond differently. Some kids may respond to medication better than others, and that's something that we see in medicine. So your question is very good, but you know, I think that it's going to take us time until we can answer the question. If it's working in the length of the bone, we have chondrocyte proliferation within the spine. So it's most likely working in the spine as well. So I will predict that is also going to be some improvement inside the spine. But again, that's, you know, I don't have data. That's all my hypothetical comment.
Great. Thank you. And I had a question for Mr. Beccaria as well. So we have several providers who are called in, I see. And I was just wondering, from your perspective with your own journey, with hearing from other families through the LCA and through everything that you're involved with, I think we as providers, Dr. Bacino talked about this as well. We try really hard to, you know, address everything that we can during a clinic appointment, think about any questions or concerns that might come up. But I just wonder, from your perspective and kind of more of the patient side, are there things that you feel like providers could be doing better, resources that you found really helpful that you think could be shared, kind of anything that you would share with providers that you think we could be doing for patients?
I'm not really shy, so I mean, if I had a question, I had Dr. Pacino's email, so I'd call him, I'd email him. I think, Amanda, you've helped me on multiple occasions with the 504 plan, getting the official letter for the school. So from that perspective, I think if I've had a question, I've just come to you guys. I think the other big thing for us has been LPA. I mean, all the members there, I've been able to go to them and ask questions. So Pam Roxbury, I met her, way back when, has become real good friends of ours because her daughter has achondroplasia as well. And I think she's a patient of Dr. Bacino's. And so she's a year older than Anna, so she's a teacher in the school. So all the schooling issues, all the activity issues, she's a year ahead of us. So I get all of that from LPA. Not only that, but, I'm able to provide back to the LPA kids to say, well, this is what we did I live in Katy. So this is what Katy ISD did. Now, granted, not all school districts are the same and not all will spend the same amount of money on the kids, but at least I can tell them the journey that I've gone through. So I think for me, I don't know that there's more information that I need. I think that, every year we get to see Dr. Pacino and, talk to him about all the trials and things that are going on. I think we're probably in a place where until the medicine's officially FDA approved and we have all the kind of things he was talking about, we probably won't take it, but I think each family is different. So from that perspective, I've gotten all the information I needed. Now, I think the hardest thing is, that Dr. Bacino alluded to is, what do I do in the house, right? Every kid's different. Some are taller, some are shorter, some need more help, some need different things. So, all you need is the resources, and then you just have to make that decision for yourself. I think that's the hardest part is, am I making the right decision? Did I do something wrong? But, I think I've talked to you guys, I've talked to friends that we've met through LPA, and, you kind of try different things. I mean, I'm sure we've thrown away a lot of stools. We've made adjustments to light switches and, created sticks with little things on them and found things on Amazon. And, people said drill holes in them and then put a little string on it. I mean, we've tried all these little different things. So, I don't know that there's a one size fits all or one answer on that. So hopefully that answered the question.
No, that's very helpful. And the LPA is definitely great. Even as a provider, when I was kind of first thinking about these conditions and learning about them, it's a great resource both for providers and patients.
Well, and then just one thing I'll also add is, they have a Facebook group for the whole United States. So that accesses some 30,000 or 20,000 members across the United States. So even if it's not the Houston chapter, this is all the moms and dads and uncles and aunts and grandparents that are there taking care of their kids or grandkids that are willing to help. And it's really a support group, a community support group. So any question you could post on there within 10 seconds, you're going to have an answer of some kind.
Right. Thank you. Well, those are all the questions that I've seen come through. We have just 1 or 2 more minutes. Are there any last questions that anybody wanted to ask before we end for tonight? Okay. Well, then that will be the end of this evening's seminar. Please don't forget to take the post-event survey if you haven't done that already. And otherwise, thank you very much to both of our speakers. If anybody has any questions or anything else that come up, feel free to reach out to us, and we're happy to talk more as well. But thank you so much, everybody.
Thank you.
Thank you, everybody.
Bye.
Ms. Berkeria. Thanks, Amanda.
Hey, Dr. Bacino.